Hi, everybody. I'm Dr. Rosie Roeder.
And I'm Andrea Spar, PA.
And we are the Rejuvaness Podcast.
And today we're going to talk about something that affects millions of people but doesn't get a lot of publicity, and that is skin cancer.
Yeah, it's not that glamorous as some of the other things that we do in dermatology or plastic surgery. And everybody wants to think of us as just the aesthetic doctors. But I think the majority of our practice is really non-aesthetic. Mm-hmm. It's medical, and it's in the skin cancer realm.
And we're going to cover the basics. We're going to talk about myths, protection, what to actually look for. And I'm going to let Rosie go ahead and tell you about the top 3 types of skin cancer that are out there.
Yeah, I think it's very important for everybody to know that skin cancer is a multidisciplinary kind of field, right? It can start with your primary care doctor just identifying something in your skin. It can start with the patient identifying changes in the skin. And then that usually generates a referral to a dermatologist or to a plastic surgeon. Sometimes it's mostly the dermatologist, and then it comes to us later on in the process. But we have skin cancers that are mainly, classified in 2 broad categories: melanoma and non-melanoma skin cancers.
Yes.
So for the non-melanoma skin cancers, we think about basal cell carcinomas, which are probably the most common skin cancer out there.
Tend to be very slow growing.
Very slow growing, can start as little red papules. The most common thing I hear is patients saying, I got this bug bite, and it just won't go away. And now it's bleeding, it's changing, it's growing. So I think that is the most common presentation I kind of see when they come to me primarily. And then there's squamous cell carcinoma, which are from the top layer of the skin, and they can sometimes present with a cutaneous horn, which looks like a little waxy papule on top of the skin.
Or keratoacanthoma.
Yep, or keratoacanthoma, which is very rapidly growing.
Volcano-like.
Looks like a volcano.
Yes.
Then I will talk about Merkel cell in the non-melanoma skin cancer, but it is a very peculiar and probably the most rare type of skin cancer. It comes from neuroendocrine cells in the skin, and they can actually be very deadly and sometimes not well identified. So I'll talk about those a little bit later. We kind of treat them almost like melanomas, but I just did want to mention them because they're rare and sometimes missed.
And can be very aggressive.
Can be very aggressive. And then melanoma is a skin cancer that comes from the pigmented cells in the body. They are probably the more likely to be aggressive and to break off and to metastasize, and it can be pretty deadly. So something we want to identify pretty early on if we can.
And I think people need to understand too, squamous cell can also metastasize if it's left long enough. So for somebody to say, oh, it was just a squamous cell, it could have killed you as well.
Yeah, actually one of my squamous cell patients has now disease elsewhere. They can sometimes be very impressive, be very large lesions. They can go to lymph nodes. They can go to other parts of the body, especially if they're left unchecked. The most common ones that metastasize are the ones from the extremities and the head and neck. And squamous cell carcinomas can be found in many other places that are not just the skin. So we don't want to confuse that. We're going to focus mostly on the cutaneous ones and not the ones that can be in other parts of the body.
And honestly, everybody should be worried about skin cancer. It doesn't pick and choose who it wants to be, but I mean, there are people that are higher candidates for getting it. Those people that have fair skin, blue eyes, those people that lived in a tanning bed. That was me back in the day. Mm-hmm. People that aren't wearing their sunscreen, but even skin of color can definitely have some melanoma. And so it's important that everybody gets their skin checked.
I got a lot of my older patients, and by that I mean patients in their 70s and 80s now that are coming in to have skin cancers treated. And I think they feel guilty that they didn't know what they didn't know.
Right.
And I try to reassure them that my dad worked for Johnson & Johnson, and I think I was one of the first J&J kiddos to get some sunscreen in the 80s, right? Sunscreen wasn't around at that time. I mean, you might have had some zinc oxide, right? The white paste that you would see traditionally on surfers or lifeguards, but it wasn't something that was very common. People weren't aware of it.
But people also wanted to be really tan too. That was the style back then. Yes. So baby oil, betadine, the works.
Yes, that was the aesthetics of the time, but it came from a time where there just wasn't a lot of education around skin cancer. Correct. And the things to prevent it. And there weren't anything that was really good and available to patients that was cheap and you could find in your grocery store like you can now. I mean, now there's just so many different types of sunscreen, and people get confused about what they should be using. They worry about an excess amount of chemicals and how that could advance their health in other ways. So our job is just to make sure that we explain the safety and that it is really important for your skin in the long run. But like we said last time, we live on planet Earth, and you're going to get sun. And when people get skin cancers in areas where they generally believe are not exposed to the sun, they also make sure to tell me that. Like, oh, I don't know how I got skin cancer in those areas. But skin cancers are not just from sun exposure.
No, they can be genetic, family history, personal history. Even people that just have a multiplicity of moles, one of those moles can eventually change. So they can definitely be atypical.
There's a two-hit theory for a lot of cancers. And that means that it takes 2 mutations, right? You have 2 genes for all the genes that you have in your body. So it takes modification of both of those for you to get a skin cancer. So this is why it's a life issue. Correct. People who present with skin cancers very early on in life definitely have a genetic predisposition and one of the genetic syndromes that are associated with it. So you're not going to have somebody with advanced melanoma who is a toddler unless they have one of the genetic mutations that presents with skin cancer in childhood. These are extremely rare. They're not common at all, right? What you will see is people who may have tendencies and changes on their moles, and they can get those early on from either just their genetic makeup or from sun exposure. But then it takes that second hit, which means that it's prolonged exposure over time, and your body's ability to check those mutations. So our DNA is very smart. And our immune system is very smart. So if there's an abnormal cell, it usually finds it and gets rid of it. As we get older, some of these things escape our immune system. And that's why most of these skin cancer presentations are in later decades of life.
Yeah, and I tell patients sometimes it can take 30 years for a skin cancer to appear. And we're seeing more and more people under the age of 40 right now with skin cancers just due to tanning beds being so popular.
And they were very popular
we
20
had
years
one
ago when
at
I was
my house.
Really?
Yes. My mother had one, so.
I have heard of people having tanning beds at their house. I guess I've never met somebody else that had one.
Yes, and then when I came to the practice, 15 years ago, I have been pasty ever since. Not pasty, porcelain.
Yes. I think you will find that a lot of dermatologists are porcelain-like.
Yes, you can always spot a dermatologist at the beach.
They're the ones where the rays of sunshine are glistening from.
Yes.
Like Twilight. I think I remember that when I read the Twilight series. I was like, oh, okay, just like how everybody should be, so they prevent skin cancer. Anyway. Sidebar. So don't feel guilty.
Yes.
All of us do things that are not necessarily perfect for our health our whole entire life.
Yes.
Right.
And don't be embarrassed to come in if something's been abnormal or in a place that you're uncomfortable with. Just have somebody get it checked, because they can say the best skin cancer is no skin cancer, but you still get things checked because most things are treatable extremely if you catch them early. Yeah.
And there are things that we simply don't know yet. But chemical exposures of the skin, we see a lot of veterans.
Yes.
We have people that have been in unusual circumstances. They have been exposed to radiation, either for medical treatment or just undue radiation due to radiation-related accidents. Then there are some chemicals that can lead to skin changes as well, and they're infectious processes.
Yeah. And there's also biologics, like patients that are on some of these stronger medicines for other diseases that they may have. It's helping that, but it can manipulate your cells to form skin cancers.
Yep, it's part of the informed consent for patients that are getting an immunosuppressive drug, be that to treat something like the skin disorders that we treat, psoriasis, or for organ transplantation. So some of the patients that I see most commonly coming in with a large amount of especially squamous cell carcinomas are patients that have had kidney, liver, lung transplants.
And it's the anti-rejection meds that they're on that they have to be on lifelong to increase the risk of that.
Right. Basically what it's doing is to prevent rejection of your organ. It's depressing your immune system. So that balance that I talked about in the beginning, that immune system check to get rid of these cells is just not present because of medication. So there's always a balance in life and in medicine about the way that we treat certain diseases that might be life-threatening can lead to other, let's say, more manageable or treatable downward, complications, let's say, or risks.
Right.
So there's no such thing as a free lunch, I guess. There's always trade-offs, right? It's about what's more important. There's certain things that you cannot prevent, but we can help you manage them and stay on top of it and see you more commonly or frequently to be able to pick things up early.
And I'd like to kind of go into detail and just kind of briefly explain what an atypical mole is and what kind we see. There's a broad spectrum. Atypical moles sit on this end, benigns at the very beginning, melanomas at the end, okay? Mm-hmm. And then there's that spectrum in between, which are those atypical moles. They are called dysplastic nevi. They go in stages. They go mild, moderate, severe, and then they have a potential of turning into melanoma. Mm-hmm. So not necessarily that you come in and you have a mole biopsy and it's showing atypia. It doesn't mean that that's actually skin cancer, but it has that potential. So the recommendation for most of our practice is, anything typically over mild, we recommend some type of treatment or removal from or good observation.
Mm-hmm. I want to point out that there's a lot of confusion with that, and patients panic when I get a dysplastic nevus diagnosis because they think they have melanoma. Mm-hmm. So again, you're on a bit of a spectrum there, from just having like a freckle or a mole to being diagnosed with melanoma. There are no studies out there that I'm aware of that has ever left a dysplastic nevus in place to try to find out how long it's going to take you to develop that into a melanoma. That would be kind of unethical, and I've never found such a paper. If there is one, I'm not aware of, and I want somebody to bring it to me. But what I have read plenty of is what happens when you, let's say, Andrea biopsy something and it comes back as a dysplastic neva. What we've done is go back and take out that biopsy site with a certain amount of margin and send that back to the pathologist. And we find out how many of those who had positive margins turn out to have missed a more aggressive diagnosis.
Correct.
Right? So for moderate and severe, it tends to be around on the 4% sampling error, meaning the biopsy didn't capture all the cells, and something that might have potentially been left behind could have been a more severe diagnosis. So that's the main reason why we go to fully excise them if they have positive margins.
Because a lot of patients, they think just because they don't see the pigment anymore that all the cells are gone, and that's not true.
That is not true. And there are some times where, depending on whether it's mild or moderate, I recommend observation depending on where it is and how close to that margin it could be. And in our business, we know our dermatopathologists really well at this point. We get frequent biopsies from them. We know the ones that we can trust. And we only work with people who see skin all day long. It's a very specific type of pathologist, and we trust our pathologists to tell us about these margins and when we should go back. So if somebody is recommending you to have complete removal, then we should probably do that. Now, there's many different ways of doing that. You can reshave it, you can do a punch, you can do a formal excision, meaning we're going to cut it out and put stitches to close it. And again, it has to do with severity, the original size, and pigmentation. For some of those mild ones, we can observe for repigmentation. If it repigments, then most of the time we're removing them just to prevent something. And again, this is the preventive step.
And I tell people you'd rather end up with a small scar now than a bigger scar later in case it did turn into something, especially the ones that are already severe.
Right. But there are people that are very moly.
Yes.
I mean,
you can't demole everybody.
And we can't demole everybody. We can't skin you. You have to have somebody who's really good and sticking out a dermatoscope and looking at them and recognizing them. So we do QA ourselves too in terms of, are we doing too many biopsies? Like if we're doing a lot of biopsies and they're all coming back benign, then maybe we should step back. If we're doing biopsies and we're picking up on things that are changing, then we're just going to look at you a little bit more frequently and then take out the dermatoscope and look at it more thoroughly, right? So just be cognizant and talk to your doctor, talk to your PA, right? And let them know your level of comfort and, are you seeing me frequent enough? Should I be undressing more head to toe? Make sure somebody's peeking in between your toes, like we talked about before.
Take your socks off.
Take your socks off. These things can happen everywhere.
Yes.
They can happen in the genitalia as well.
They can happen in the scalp. And I tell everybody, do you go to a hairdresser? And the reason I ask is because hairdressers are even trained to say, hey, there's something up here you need to have looked at. So if they tell me they see a hairdresser every week and I'm looking through their hair and I don't see anything, I'm like, okay, yeah, their hairdresser's pretty good.
Yeah.
Yeah.
And your nail tech person too.
Nail tech person.
They should also be trained to look for different pigmentations in the skin. And I have people that come to me saying that my hairdresser found this and my nail tech found this. So they're really adjuncts to all of this.
I've had somebody recently come in and say their masseuse found a mole on their back and they had a history of melanoma. So that was good that they came in.
That was really good. Estheticians do a good job too. And I'd rather you get checked out by somebody for anything that's questionable than have that doubt in your mind, or then a year or so later regret that you didn't have that mole biopsied or completely excised.
Now, melanoma has their ABCDE thing that we kind of go by, and I explain that to my patients. Do you want to go through that briefly?
Yes. So you want to look at a mole, you want to look for asymmetry. That's the A. So if it's not a perfect circle and it has, I guess we would say, like just different shapes that are kind of oddly shaped, that's one thing. And again, all of these are different signs, and there are some moles that are asymmetrical and are totally normal.
Correct.
But you want to try to look at the spectrum of this, because these are the things you should be bringing up to your medical provider if there's asymmetry on that mole. B is for borders. You want to look for, again, like irregularity on these borders or changing and evolving borders. I guess that's the E. I'm kind of
you're good
into there. But then C is the color.
Right.
So if the color is changing and getting darker, especially, or sometimes if it's white. So there's something called halo nevus, and that's your immune system trying to clear out that pigment.
Mole.
It's trying to attack that mole because it's abnormal. So if you see changes in pigmentation, not just darker pigmentation, but also lighter pigmentation within a mole, just bring it up to somebody, because it could be that your immune system is trying to clear that pigment.
And the size portion of this is a hit or miss for me, because I've seen melanoma that's 2 millimeters, but things that are over 6 millimeters.
Right. And that's the D. It's the diameter of that particular lesion. The bigger it is, the more likely, because you will have more cells present.
Correct.
Right. And the more cells, the more chances that something will change. So you want to look at the diameter. And then the E is evolving, meaning something is changing, visibly changing. Mm-hmm. So if you have a mole that you have seen, take a picture of it. You can bring it up to your doctor. You can bring it up to your dermatologist. If you have a really good dermatologist, they are taking pictures of your moles. They're documenting the size. There's something called dermatoscope. Mm-hmm. You can look through that dermatoscope. It amplifies the mole, so you can look at the pigment a little bit more closely.
Again, that's that colors and chaos that I talk about that we're trained to look for in the moles.
Mm-hmm. And so you want to have that documentation. You want to have that picture. If somebody's measuring and observing a mole, they will take serial pictures of it. Mm-hmm. You can do that yourself as well. You can even ask your dermatologist to note it and take a picture on your own phone that you can then look again in like 3 months. Have a family member, especially if it's on the back. If it's somewhere it's visible for you, you can track it yourself, but you can ask a family member to take pictures. And if you visibly see changes, because one of the things that people don't take into consideration is that if you're looking at yourself or at a mole every single day, you're not going to pick up subtle changes.
Correct.
But if you take a picture of it today and look at it in 3 months, you will be able to appreciate a change that maybe you didn't appreciate on the day-to-day.
Now, other things I tell my patients, it doesn't have to be pigmented.
Right.
There's amelanotic melanoma. It can be a pink color. It can be, we talked about more white, clear. So even the subtle changes in your skin, I recommend getting looked at, because like I said, the sooner you catch things, the easier it is to treat them. New bumps, scrapes, cuts that aren't not healing, scaly places. I tell my patients that I give anything the benefit of the doubt. Sometimes as we age, things take a little bit longer to heal, but if it's longer than 6 weeks, they need to call me so I can take a look and try and make sure we don't need to do a biopsy on something, because sometimes bug bites take that long. Yeah. And right now, ants are attacking everybody's feet. They're like, oh, that's an ant bite. I'm like, okay.
Yeah, it's that ant bite that never heals, doesn't itch that much.
Yeah.
It's probably not an ant bite, right?
Probably not.
And I have seen cancers that I looked at it with my naked eye, and I'm like, for sure this is a basal cell. It's pearly, it's raised, it's pink, and then I get the biopsy back and it's a melanoma, right? So 98% of the time I'm going to be correct that that's a basal cell, but getting that biopsy and getting that pathological determination under the microscope really is critically important to make sure it's treated adequately.
Correct.
So for melanoma, it's very important cancer to stage adequately. And melanoma is staged initially based on the depth
of the biopsy, which usually starts with a punch biopsy.
Yes. You want to do a punch biopsy. I know a lot of people shave. Sometimes I shave moles myself. You want to shave it deeply enough. But as somebody who is going to treat that patient, especially surgically, when you look at a melanoma biopsy, it's like full of things, right?
Yes.
It's going to address multiple things. The depth being the most important one, because that determines whether or not this is just a straight up surgical resection and what margins, meaning how much normal looking tissue you need to take with it, or if it needs a lymph node evaluation.
Correct.
So traditionally, that depth is 1 millimeter. Anything above 1 millimeter should go to a lymph node examination that's called a sentinel lymph node biopsy. It really just samples what would be the 1 or 2 lymph nodes that drain a particular patch of skin where that skin cancer is present. Now, if it's greater than 0.8 millimeters but has ulcerations or other concerning features,
then it still should probably go.
It should go also to a sentinel lymph node biopsy. Now, there are some thinner melanomas that you might consider doing a sentinel lymph node biopsy if you do a genetic evaluation on that tumor and it says it's on the aggressive side. You can usually then maybe favor doing a sentinel lymph node biopsy, or at least offering it to the patient. But anything less than 8 millimeters generally just goes to straight surgical resection, which a lot of us will do in the office if it's a reasonably size of the original lesion and the patient is an adequate patient for that. We can usually do this under local anesthesia in the office safely. If it requires a sentinel lymph node biopsy, you have to go to the hospital because we need to involve the radiologist. They're going to inject a radioactive tracer on that biopsy site. We got to give that about 30 to 45 minutes to get picked up by the lymphatics to go to a lymph node. And then in surgery, we are going to identify that. We use all sorts of technology to find the nuclear medicine tracer, and we're also looking at the picture that was taken to correlate with that. And then we remove that lymph node. That gets sent to a pathologist. It usually takes about 3 days to get the results back. So unlike some other cancers, we won't know that your lymph nodes are clear on the day of surgery.
Correct.
I have seen lymph nodes that were enlarged, they were boggy. Some of them that were even like a purplish dark color that turned out to be negative for melanoma, and some that looked totally fine and were positive. So our naked eye can't tell that at the time of surgery, but we wait for that kind of staging procedure. And then if we find that that lymph node is positive, then we'll do something called a PET scan. It will scan head to toe to see if there's any lesions anywhere else in the body, and then you'll be sent to an oncologist who will give you what mostly immunotherapy is what we have now. When I first started in medicine, we used to have very awful treatments for melanoma, and it was definitely almost a condemnation. Like, we have patients in very awful interferon. There was poor quality of life. And now we have fantastic treatments with much less side effects than in the past. I mean, we had, former President Jimmy Carter, who lived to be 100, having had melanoma that was even metastasized to his brain. And I have patients that now have turned their melanoma into a bit of a chronic disease. I hate to say it that way, but the immunotherapy has them living a lot longer than was possible in the past. So it's not a death sentence. It's definitely super aggressive, and for some people, there maybe won't do as well, but we have much better treatment, and coming to see somebody sooner than later is very critical in that.
Yeah. And so if you see something weird, get it checked out.
Absolutely, get it checked out.
So in general, we're going to talk about a couple of ways of how to reduce your chances of skin cancer. My main thing is wear your sunscreen 365 days a year. All right, every single day. If it's cloudy outside, you still need to be having at least a 30 SPF in it. A lot of patients say it's in my makeup, and I have to reiterate to them, you have to use a whole tablespoon of that makeup to equal the SPF that it's telling you that's in it. So even just a tinted sunscreen can definitely help. UPF clothing or SPF clothing can help. Even avoiding peak hours of the day, which is between 10 and 4, but it's the hottest between 10 and 2. And then doing at-home monthly skin checks and seeing your dermatologist at least yearly to make sure nothing else is going on.
Yes, and definitely come get something checked out whenever you notice any changes. And if you see it in a loved one, point it out to them as well. You might be saving a life.
All right, and just a reminder to get your skin checked. So you've been slacking, go ahead and book it.
All right, so we talked a lot about melanoma, so we're going to do a part 2 where we talk about non-melanoma skin cancers. Sounds good?
Sounds fabulous.
All right, well, I'm Dr. Rosie Roeder.
And I'm Andrea Spar, PA.
And we are the Rejuvaness Podcast. We'll catch you next time with part 2.